So should we start?
Yes, we are waiting for you.
Yeah. Corona people, please, will you start or we should start with ourselves?
Yeah, we can start. I just want to ask one thing, ma'am. I need to share the PPT or like,
No, sir will share the PPT.
okay,
You
so
have
we
to
can
share
start.
the CV PPT. CV PPT.
Okay, I'm sharing my PPT now.
You need to share PPT of speaker's introduction,
Yes, sir.
chairperson's
Yes.
introduction, Sapan.
अगर
So-
आप ये कोई इनॉग्रेशन में कोई गणेश वंदना वगैरह लगा रहे हैं तो वो लगा दीजिए.
हाँ. So first of all, good evening, all the faculty members. On behalf of Corona Remedies, I would like to welcome each one of you for this eco webinar series on enhancing care for healthy outcomes, focused webinars for obstetricians and gynecologists. Before moving forward, we can start with this prayer. So I'm just playing this prayer. Okay, now over to you, Monica ma'am.
Good evening, everyone. Welcome to the 4th episode of our Eco webinar series. It is our fourth episode, and each time we are doing with a different zone. We did with the east, west, north, and south, and today we are doing with the west zone. Today, our program director, Dr. Kalyan Barmade, will introduce our chief guest, Dr. Parag Beniwale. I request Kalyan sir to introduce Parag sir. Over to you, Kalyan sir.
Yes, please. Good evening, everybody.
Please change.
It gives me a pleasure to welcome you all for the 4th episode of Obstetricians and Gynecologists Eco Webinar Series. This series has been designed with a very clear purpose to create a regular academic platform where practicing OBGYN across India can come together, learn, and exchange practical insights. Each week, we will focus on a single important topic in obstetrics and gynecology. The format is included a lecture by a distinguished national expert, a teacher of teachers, followed by a case-based panel discussion that brings theory into real-life practice. Our aim is to make this clinically relevant, interactive, and practice-oriented series that benefits every gynecologist, whether in an urban center or a small town. We are very happy to involve Surat and Himmatnagar societies from Gujarat and Ganganagar and Alwar societies from Rajasthan. And for this week's episode, I am very delighted to have our chief guest, Dr. Parag Beniwale, sir. He's a senior consultant and obstetrician gynecologist from Pune. He's a president of ICOG or chairperson of ICOG. He's a PG teacher and unit head, Kamla Nehru Hospital. President of Menopause Society Pune 2018-22. President Pune OBGYN Society 22-23. President ISOBA Pune Chapter 24-26.
Kalyan, thank you. Don't waste time in reading that. That's okay.
Yes, sir. We need your blessing for this eco webinar, sir.
So, thank you. Good evening. I bring greetings from the city of Pune, and it's indeed a pleasure to be part of the webinar that is Eco Series. So, at the outset, let me thank Dr. Kalyan and the conveners, Dr. Monica and Dr. Monica, for having me here today. Kalyan, I must appreciate your efforts because the topics that you've chosen today are really useful. Osteoporosis is a silent killer, and we as healthcare providers for women should be very well aware about it. And we could not have asked for a better speaker than Dr. Rajendra Singh Pardesi, who has done original research work in the field of osteoporosis. So I'm really looking forward to this learning experience. And of course, the topic for the panel that you've chosen, fever in pregnancy, is something which we obstetricians always dread because, then we start wondering what could be the cause. It could be anything, right from the urinary tract infections to any sepsis, or during COVID times, any fever which we had was labeled as COVID unless proved otherwise. So I'm looking forward to some interesting discussions, and all the panelists, I'm sure, will contribute to the healthy discussion of this topic. And thank you once again for having me here, and thank you for having Dr. Veena Acharya and Dr. Kiran Kurtakoti as the guest of honors with me, sharing a virtual dais with me. My best wishes for the program and best wishes to your future endeavors. Thank you.
Sir,
Thank-
please join.
Thank you, Parag sir, for your words of wisdom and blessing for this webinar. Now I'd like to introduce guest of honor, Dr. Veena Acharya, madam. Can we have CV of Dr. Veena, madam, please? उसके पहले का और एक पहला. So Dr. Veena Acharya, madam, is a senior consultant and head of department of OBGYN, preventive oncologist of Rajasthan Hospital, Jaipur, chairperson of governing council ICMCH, that is Indian College of Maternal and Child Health, NARCHI, India, president of Rajasthan branch of NARCHI, JOGS, ISCCP and Fertility Society, patron of Association of Gynec Endoscopic Surgeons of Rajasthan, National Executive Member of ISCCP and Director of Colposcopy Center and National Executive of ISCCP. Awarded Chikitsa Bhushan on Doctor's Day in 2018. Appreciation Award by Foxy in Postgraduate CME. Faculty of Prince Sangolika University, Thailand. And has given many national and international lectures. So over to Dr. Veena, madam, for words of blessings to all of us.
Very good evening to all. It is really matter of great pleasure for me to join with all the stalwarts. Thank you, Dr. Monica. She just invited at 6 o'clock me. That madam, today is also there is a program, and I'm so happy to see the program because this program is really very topics are very relevant to our day-to-day practice. And Dr. Parag Beniwal is rightly point out that is the need of ours, that we should discuss this type of discussions, which is really need, because osteoporosis, as we say, it is a silent killer in the women, and osteoporosis is a major public health problem in India. Almost India has the maximum women with osteoporosis, and women are not realizing, because in day-to-day practice their diet, their way of living, their lifestyle, they all are contributing. They only come when they have the problems. So that is the important message we want to give, the awareness and actions. So when everybody, it is responsibility of everybody that we give the awareness in the public regarding the health of the women, and that will definitely give the impact in the societies. And I'm also very happy to see the another panel discussion, which is the fever in pregnancy, because sometimes most of the women are ignorant about the normal fever. Okay, we will take some medicines, but it really problem lot many things. So I'm thinking once again, thank you, Dr. Kalyan, for giving this opportunity, and Dr. Monica, and we will happy to listen to all the things. All the best wishes for this series. Thank you so much.
Thank you, Veena ma'am. We are always happy whenever we say anything to you. You never say no. You are always with us, and we are blessed to have you as our mentor.
Thank you, my dear. Thank you, my dear.
Thank you, ma'am. Now we are proceeding to our academic session. We are having a excellent talk by Rajendra Singh Pardesi sir on osteoporosis, which is a burning topic today because most of our life is spent in the menopausal age group. For that, we have got three chairpersons with us: Dr. Abha Sapra, President, Alwar OBGY Society; Dr. Sarfraz Kaji, President of Himmatnagar Society; and Dr. Sarita Opneja, President of Ganganagar Society. So I request Dr. Kaji to introduce our chairperson, our speaker, Rajendra Singh Pardesi sir. and
Monica,
invite him for the talk.
Monica, Dr. Kiran Kurtikote has joined.
We
Acha,
have
sir
just,
has joined. Okay, sir, I have not seen him. Okay.
he has just joined.
Acha, he has
Yes,
joined.
yes.
Sorry.
Sapan,
we
can
will
you
take-
just have his CV, please? Dr.
No, it's okay.
No,
Kalyan sir.
Kurtakoti is president of AMOGS, that is Association of All Maharashtra OBGYN Societies. He is heading this post since last 2 years, and he has many contributions to AMOGS as well as FOXY. He was a FOXY chairperson of MTP Committee 2009, chairperson MTP Committee AMOGS 2012, chairperson Medical
Okay, sir.
AMOGS.
Kalyan sir, it's okay.
Yes,
There is
thank you,
one
sir.
point, big point. There is one point missing in the CV, friend of Dr. Kalyan Baramade. So that I am going to add next time.
One more
So
one
thank
more
you.
point missing in the CV: mentor for almost all Amoxians and Foxians.
Arey kuch bhi Kazi sir. Anyway, thank you,
He
Kalyan
has
sir.
got
Thank
a
you
lot
for
of publications, and over to you, Sir Kiran sir, for words of blessing.
yes, sir. Well, thank you, Dr. Kalyan sir, for inviting me as a guest of honor. And you know what you have done is really fantastic. And by starting, Dr. Kalyan sir, main activity for this year that you have started the state chapters of IIG. I think that's a very very big thing that you are doing for IIG, and I really congratulate you. And I assure you that as far as Maharashtra is concerned, Maharashtra is always there with you, and the state chapter will also contribute to the further progress of IIG. Thank you, and my best wishes to you, and of course to this webinar. My regards to Dr. Pardeshi sir. I can see Dr. Pardeshi sir, and my regards to Dr. Deepika, Dr. Abha, Dr. Indu, Dr. Savita, Dr. Sarita madam, and a big hello to Dr. Kazi. Kazi has been doing a very good work. So Kazi, hope to see you and see you shortly. And next week, I take this opportunity to invite you to
We
Pune for the Star Sampurna conference of Dr. Sunita Tanwalkar.
definitely.
Pranam to Dr. Veena Acharya ji. Thank you. Thank you, Kalyan sir. Thank you
Thank
for
you, sir,
inviting me.
for
Thank
your
you.
words of blessing. Now, can you just share CVs of Pardesi sir? Yeah, Dr. Sarfraz Kazi, you can introduce sir.
Yes, sir. Yes, sir. In one word, if I want to introduce Dr. Rajendra Pardesi sir, is the big legendary Foxian who is the another mentor for small Foxians like us, and who is promoting all the young generations, all the academicians, all the Foxians to the big, for giving the big platform. If I will introduce Rajendra Pardesi sir, 7 times best paper awardee in Foxy's AICOG conference, and he is the faculty in many national and international conferences. I met him in FIGO also. He was doing great work. Since 2006, he is attending all the FIGOs as a faculty, and he was the VP in 2019 and 20, and VP of AMOX in 2018 and 22, and now president of AMOX last year when I attend the conference of the AMOX first time. Over to you, Pardesi sir.
So I'll have only one word for him. He's the one who has brought me into Foxy. So pranam to Pardesi sir. Thank you, sir, for everything in him.
Same for me.
Over to Pardesi sir for his academic lecture.
Hello, can you see?
Yes,
Hello?
sir. Yes. Please.
Yeah.
continue.
Sapan, make
Yes.
it full slide.
Full slide. Okay.
Yes, sir.
Okay. I am feeling proud to present this topic in front of Dr. Parag Biniwale, Dr. Veena Acharya, Dr. Kiran Kurtakoti. Thank you, my younger brother, Dr. Kalyan Baramde, Dr. Monica Umbardan, and Dr. Monica Gupta, convener, and Jagruti Desai, expert. So this is topic of my interest. Osteoporosis, the silent killer. My mother, who laid the foundation of culture and taught me to respect women, and my wife, who allows me to be a better man as I hold her hand while she finds her new career. She, osteoporosis, how hampers the life of woman. Osteoporosis, a systemic skeletal disease characterized by low bone mass and microarchitectural deterioration with a consequent increase in bone fragility with susceptibility to fracture. It's not an inevitable part of aging, it is preventable. So it is vital that all of us of all ages start taking care of our bones now before it is too late. All see from childhood, I'm feeling very sad. Childhood are like children's. There are other dresses and all those girls. Then she will enter in younger age. So all like after marriage. So husband likes, then children, then in-laws and all those daughter means. So after menopause, she will be alone. She will be facing many problems of menopause, and osteoporosis is the main, and that is when we have to act. Osteoporosis is both a preventable and treatable disease, and there is a number of effective, well tolerated therapies that may significantly reduce a person's risk in addition to lifestyle change such as improved diet, increased exercise. Let us see estrogen and the skeletal system, because estrogen deficiency is causing osteoporosis mainly after the menopause, and there is accelerated bone loss which mounts to about 1 to 1.5% loss of total bone mass per year. And first 20 years after cessation of menses, menopause related bone loss results in 50% reduction in trabecular bone and 30% reduction in cortical bone. See, this is normal bone and right side is a osteoporosis. See, this is normal iliac crest and this is osteoporotic iliac crest. So estrogen is important. So let us see estrogen and skeletal system. The precise mechanism is not known, but it acts at different sites. Increased efficiency of calcium absorption, direct action on osteoblast through stimulation of estrogen-dependent growth factors, and promotes the systematic of calcitonin. See, estrogen and the skeletal system. This is the data from US. This is the fractures. See, these are the risk factors, family history of osteoporosis, early natural or surgical menopause, previous fragility fractures, smoking, low body weight, medical disorders. Depending on clinical risk factors alone is inadequate. Still, 30% of women with no risk factors have significant bone loss. This is very important. These are the pathophysiologic factors for osteoporosis. Now, see the estrogen and the skeletal system. The peak bone mass determined by genetic and non-genetic factors, and rate of bone loss in later life, aging, lifestyle, the menopause, smoking, etc. Now, let us see what is BMD test. Traditional X-rays can't measure bone density, but they can identify spine fractures. Bone mineral density has to be measured by more specialized techniques. A number of different types of BMD tests are available, but the most commonly used is DEXA, that is dual energy X-ray absorptiometry. DEXA is low radiation X-ray capable of detecting quite small percentage of bone loss. It is used to measure spine and hip bone density and can also measure bone density of the whole skeleton. And there are a number of different test options also in this. See, these are the different options: DEXA, then quantitative computed tomography, single photon absorptiometry, and these are the other newer techniques, and other techniques also are available, but DEXA is a gold standard. So DEXA, the technique depends on measuring the low bone mineral content, is a clinically relevant area of the skeleton, example vertebra or hip. The BMD is obtained by dividing the bone mineral content by the area scanned. The result is expressed as Z score, that is SD, from patient age mean value and T-score SD from adult standard value. As you know, I don't want to go in detail. This is T-score. T-score is the diagnosis of osteoporosis is based on this. T-score more than -1 is normal. During -1 to -2.5 is osteopenia, and -2.5 is osteoporosis. See, this is DEXA report. How the reporting has been done. This is a spinal. Now, BMD measuring using ultrasound also. The site of measure the phalanx. See, he fractured due to osteoporosis. The four major goals in the treatment of osteoporosis: prevent fractures, stabilize bone mass, or achieve increased bone mass, relieve symptoms of fractures and skeletal deformity, and maximize physical function. The US General Surgeon has recommended a three-level pyramidal approach to treatment in order to achieve these goals: that lifestyle changes, then treating secondary causes, and pharmacological intervention. Lifestyle changes from the base of the prevention and management pyramid, including adequate calcium and vitamin D intake, physical activity, and fall prevention. And the second level includes assessing and treating secondary causes. The third level includes pharmacological interventions to improve bone density and reduce the risk of fracture. If pharmacological therapy is indicated, FDA approved options are estrogens, bisphosphonates, calcitonin, and PTH. See, this is the chart where the drugs used on vertebral and non-vertebral. And this chart shows magnitude of the treatment effect on vertebral and non-vertebral fractures in postmenopausal women with osteoporosis. And this chart shows therapeutic management of postmenopausal osteoporosis. This is the algorithm of postmenopausal woman where osteoporosis therapy has been substituted. See. Now, osteoporosis, two types of therapies: physical therapy, chemical therapy. In physical, physiotherapy; orthopedics; in chemical, anti-resorptive drugs and hormone replacement therapy. Anti-resorptive drugs, the decreasing the action, the decreasing the imbalance between bone resorptions and bone formation. They act like this, decreasing the overall rate of bone turnover, or by both. Examples are calcium, vitamin D metabolites, calcitonin, and gonadal steroids. Hormone replacement therapy for women within 10 years from the menopause, contraindicated to estrogen therapy in breast cancer, uterine cancer. Hormone replacement therapy is prone to estrogen complications. Now let us see anti-resorptive agent estrogen. It acts directly on bone cells through high affinity estrogen receptors. Exact mechanism not known. I told you before also. At menopause, when estrogen level decreases, bone turnover increases with a greater increase in bone resorption than bone formation. Around 33% of all bone loss in women may be attributed to menopause. Calcium, amount of absorbed calcium is insufficient to offset the obligatory losses in urinary and feces. Bone loss ensues. Postmenopausal woman, calcium supplementation may decrease bone loss. Then calcitonin, it inhibits bone resorption and has analgesic properties also. Parental calcitonin increases vertebral bone mass with postmenopausal osteoporosis. Intranasal calcitonin therapy retards the postmenopausal bone loss. And these are the disadvantages of that. Calcitonin, unlike estrogen, calcitonin may not reduce cortical bone loss. Resistance developed as CT from non-human sources. Side effects including flushing, nausea, and nasal irritation. No oral form, expensive. Bisphosphonates, they are the important component, the potent inhibitors of bone resorption. Then the anti-resorptive drugs includes anabolic steroids. They increase bone mass in women. They stimulate bone formation. But some disadvantages are there, like androgenic actions affect plasma lipoprotein adversely, induce hepatic dysfunction. Then calcitriol, The active vitamin D metabolite or its analog, like alpha calcidol, it acts by increasing calcium absorption, but may also stimulate the function of osteoblasts. It improves calcium balance and decrease the rate of fracture, transient hypercalciuria, and hypercalcemia. So, prevention will be done by adequate osteoporosis. Prevention is very important. Adequate calcium intake. Then RDA is 1200 milligram during skeletal growth, 800 to 1000 milligram for adults, and 1000 to 1600 milligram for the elderly is the dose. In postmenopausal woman, calcium supplement alone is not the substitute for vitamin D metabolites. In elderly, impaired calcium absorption, increased parathyroid function, and increased bone turnover. Therefore, it is important to correct the defect in intestinal calcium absorption by the administration of vitamin D metabolite. Corticosteroid induced, let us see corticosteroid induced osteoporosis. This is also important. Corticosteroid cause sodium retention and calcium and potassium depletion. Prolonged corticosteroid therapy leads to calcium depletion, resulting in osteoporosis. These are the all conditions, these are the indications for prescribing corticosteroids: asthma, rheumatoid arthritis, ulcerative colitis, organ transplantation, SLE, nephrotic syndrome, collagen disease, autoimmune disease, malignancies, cerebral edema. Vitamin D preparations are not recommended in steroid-induced osteoporosis. Vitamin E is to be administered only in substrate deficiency condition like lack of UV light, inadequate vitamin D diet. Combination therapy of vitamin D plus calcium is not effective in steroid-induced osteoporosis. The only one and only answer of the problem is alpha D3, that is alpha calcidol 0.25. Alpha D3, which is specific action, prevents steroid-induced osteoporosis by increased activation of bone growth factors, inhibits the synthesis and release of parathormone, increase in trabecular bone volume, improves gastrointestinal calcium absorption, useful in transplant surgery and bowel distress, vertebral bone loss prevented by calcitol. Let us see hormone replacement therapy. HRT consists of estrogen alone or combined with progesterone. Additional benefits of estrogen are lower risk of ischemic heart disease and treatment of direct menopausal symptoms. The other related diseases are hypocalcemia, that is low concentration of calcium in blood. These are the causes of hypocalcemia. Then hypercalcemia, it is high concentration of calcium in the blood. Now, let us see on phosphates. The phosphates is a structural and functional component of the bone and teeth. About 85% of phosphate is present in bone as calcium phosphate salts. Phosphate is principally an intracellular electrolytes. These are the pain management options in osteoporosis. Patient to patient is different, but you can give these agents. These are the calcium recommendation, as I told you before. This is the calcium recommendation, 800 mg daily for children, 1000 mg for males, premenopausal women and postmenopausal women, 1200 milligram daily teenagers and young adults, 1500 for postmenopausal women, 1200 to 1500 pregnant and nursing mothers. Total daily intake of calcium should not exceed 2000 milligram. Nutrition in the management is very important for bone, muscle, and joint health, and it is closely related. Two of the most important nutrients are calcium and vitamin D. Now, let us see recent updates in the management of osteoporosis. See, this is paper. These papers are presented by me only, 3 or 4 papers. See, zoledronic acid plus denosumab, a magic combination in the management of severe osteoporosis with high fracture risk. The conclusion: in postmenopausal women with severe osteoporosis with high fracture risk treated with IV zoledronic acid plus denosumab increases BMD at all major skeletal sites, finally reduces fracture risk and quality of life in total. This is my second paper, Effect of Lactation on Maternal Bone Health. To conclude this paper, the conclusion is even there is no consensus about bone loss during lactation or the long-term effect of lactation on bone, we should be cautious about long-term effects if not treated in time. Vitamin D deficiency may be an important contributory factor on post-lactational maternal bone health. Vitamin D and calcium played as important role in bone formation and ibandonic acid as anti-resorptive agent. Now, this is really an interesting paper, that is postpartum osteoporosis in a young female, 20 years female, a rare case with a new lesson. Conclusion is postpartum osteoporosis is therefore associated with significant morbidity, a high prevalence of recognized risk factors for osteoporosis, and risk of recurrence in subsequent pregnancies. Hence, is the main concern. Bisphosphonate therapy administered soon after the presentation substantially increases spinal bone density in these patients, with which already seen with increased her generalized condition and ability to walk. Bisphosphonate with calcium supplementation plays important role to relieve symptoms of osteoporosis. This is very interesting case in where there are hardly up to 600 cases noted. This is fourth paper I presented in Indore AICUG that COVID-19 infection affects bone health in women. With conclusion, this study, even having less numbers in study groups, suggests definite correlation of COVID-19 infection on bone health of women in all age groups, irrespective of their treatment with corticosteroids or other agents. All osteoporotic women with COVID-19 infection were above the age of 60 years, suggestive of impact of COVID-19 over old age is definitely more than younger group. Surprisingly, younger group bone health is definitely affected by COVID-19 infection, which is alarming to us and should be taken care of. This study is totally different and suggested a new window of studying the effect of COVID-19 infection on bone health of women of all ages. In SARS 202 and 24, they were telling there is no effect of SARS also, and even COVID-19 also bone health. But now ICMR has released their bulletin that COVID-19 has definitely effect on the bone health and more on women's bone health. Prevention is always better than cure. Isoflavones, a natural alternative. Isoflavones has been proposed as a natural alternative to hormone replacement therapy. Advantageous effect of isoflavones on frequency and severity of hot flushes in perimenopausal women. These are the silent features of soy isoflavones. I don't want to go in detail, and this is mechanism of soy isoflavones. The isoflavones on menopause women with climacteric symptoms is very useful, significantly reduces hot flashes and night sweats in menopausal women. See this paper, the effect of soy isoflavone combined with calcium on bone mineral density in perimenopausal Chinese women, a 6-month randomized double-blind placebo-controlled study. Isoflavones combined with calcium therapy was effective and safe in alleviating perimenopausal symptoms and improving participants' quality of life. This paper, the soy isoflavones prevent bone resorption and loss, a systematic review and meta-analysis of randomized controlled trials. The isoflavones prevent osteoporosis-related bone loss in any weight status on treatment duration. They increase BMD in normal weight subject and diminish bone resorption in overweight, obese individuals. See, isoflavones reduce cardiovascular risk. Isoflavones lower the cholesterol by about 9%. It reduces cholesterol metabolism, enhances bile acid secretions. ACOG positions inside that long-term intake of soy and isoflavones may improve blood cholesterol levels. Blood isoflavones definitely lower blood pressure. Isoflavones, they told, the activates on breast and uterus. They induce apoptosis, inhibits cell proliferation, and inhibits differentiation in cancer cells. It definitely reduces the obesity and diabetes also. And it is safe. So isoflavones elevates menopausal symptoms by reducing hot flashes. It reduces frequency and severity of hot flashes, reduces night sweats. To summarize this, isoflavones alleviates menopausal symptoms by reducing hot flash. Moderately doses of isoflavones are efficacious for promoting bone health. Exercise is very important. Mental and physical along with social health together forms the health. Exercise plays very important role in maintaining good health. Morning exercise increases production of endorphin, ultimately causes charge feeling in good manner. Morning walk, yoga, pranayam can be tried. Exercise is very important. While virtually all physical activity reduces the risk of cardiovascular disease, swimming and cycling, for example, will rarely augment bone mineral density. Make a lifetime commitment to physical activity and exercise in terms of bone well. Weight-bearing activities such as basketball, volleyball, and gymnastics are more effective than weight-supported activities such as swimming and cycling. The main role of exercise in young adults and premenopausal women, therefore, is to maintain BMD rather than to increase it. These are the recommendations for young adults and premenopausal women. Warm up to 15 minutes, high impact jump for 20 minutes, stretching and non-impact activities for 15 minutes, cool down for 10 minutes. Besides maintaining bone health, bone strength, the main goal of exercise therapies postmenopausal women is to increase muscle mass in order to improve parameters of muscle function such as balance and strength, which are both important risk factors for fall and independent of bone density, risk factors for bone fractures. Now see yoga and exercise. These are the yoga poses. It's very important. I don't want to go in detail. All you are aware of is Surya Namaskar poses. Now see real enthusiasm. We met these three females enjoying at Rohtang Pass and they are fit. Thank you so much for giving this opportunity. Thank you so much.
Thank you, sir. Thank you for such an excellent talk. You have really worked so much on osteoporosis, so you really can make a real verdict what to do and what not to do. I request Sarita Upneja madam and Abha Sapra madam to say a few words on it.
सर ने सारे टॉपिक पूरे अच्छे से कवर कर लिए, लेकिन लेडीज के लिए एक बात नहीं बोली कि डांस ऑल्सो जो है वो हमारे ऑस्टियोपोरोसिस को प्रिवेंट करता है। ये आपने ये टॉपिक नहीं बताया। जो हम लोग वेट बेयरिंग एक्सरसाइज जितनी भी है उसमें डांस भी एक अच्छा टॉपिक है उसमें, और हम उसको करते हैं। बाकी आप
yes, I will include in next.
हाँ,
हमारा गरबा भी इंक्लूड कर लेना सर।
Yes, Garba is also very important. Zumba and other dances are also important.
जो हमारे सनातन में देखो शुरू से ही हम लोगों को इस तरह से हमारे जीवन को डाला हुआ है कि हम लोग सब कुछ कवर कर लेते थे, खाना पीना सब। अब हम लोग मॉडर्न हो गए, हम लोग सारा दिन मोबाइल पे लगे रहते हैं, चलते फिरते हैं नहीं, घर में बाइयां काम करने वाली हैं, मॉर्निंग वॉक भी नहीं करते, तो हम लोगों को थोड़ा अपना लाइफस्टाइल चेंज करना पड़ेगा अगर हमें ऑस्टियोपोरोसिस। थैंक यू वेरी मच।
Thank you.
Dr. Abha Sapra ma'am, are you there? I think she has left.
Excellent talk, Paradesi sir. It was enlightening session on the osteoporosis, and you made the complex concept very simplified, and highlighting the preventive strategies was both inspiring and impactful. Thank you very much, both the Monikas, I will say twin Monikas, Monica Gupta and Monica Umberman, for inviting me and for this prestigious session. And Mr. Paradesi sir, for your presidential candidature in 2028, and best of luck, Kalyan sir. We all are with you for your candidature this year for Vice President of West Zone.
Thank you, Dr. Kazi, for these good words. Sir, Pardesi sir, thank you for your talk, which was more of your experience than anything else. And your work in osteoporosis, the paper presentation, the national and international are really worth listening for this generation because you are doing this work on osteoporosis since 2006. So I congratulate you for the same and thank you for coming for this webinar.
Sir,
Dr. Monica, we'll move to the second session, please.
excuse me, sir, I want to say something.
Yes, ma'am.
हाँ, मैं ये कह रही थी कि डाइट के लिए जरूर डालिए कि हम लोगों को मेनोपॉजल एज में क्या चीजें हमारे डाइट में ज्यादा खानी चाहिए.
Yes, madam. Yes. Actually, it's a quite vast topic.
डाइट के लिए बताइए, मिलेट्स खाने हैं, सोयाबीन खाना है, ये आप उसमें एक चीज
And we will have a separate session on the diet in the menopausal and perimenopausal age group because it is a vast topic and it will take another half an hour to discuss on it.
Yes.
Next time we are definitely going to keep it. Now we are moving to our second session for what
Yes.
all we are waiting for. That is a panel discussion on pyrexia and pregnancy. I request Deepika to introduce our moderator, Kalyan sir, our expert Jagruti ma'am, and the panelist. Over to you, Deepika.
So can I have the CVs for sir? Can you hear me, Dr. Monica?
Yes.
Okay.
Very good.
Okay.
Please show the CV of Kalyan sir.
पीछे चला गया. Yeah, so it's my honor and thank you, Dr. Monica, for giving me this honor. It's my honor to introduce our star moderator, and he's the organizing chairperson for this entire series, Dr. Kalyan Barmade sir, who is the president of IAGE, and sir is a
Thank
leading.
you, ma'am, for this introduction.
Sir,
Dr.
thank you so much for giving me this opportunity, and we are looking forward, all of us, for this session on pyrexia and pregnancy. It is like going to be very important for us and a very clinical topic that is important for all of us who are dealing with pregnancy patients. Thank you, sir. Can we have the our next CV, please?
Next, please.
Jagruti.
Yeah, so I would like to invite Dr. Jagruti Desai ma'am, who's going to be the expert for this panel discussion. Madam is in private practice at Udana Hospital and is a visiting consultant at Nirmal Hospital. Ma'am is a leading obstetrician, gynecologist, and laparoscopic surgeon with special interest in infertility. Ma'am is President Menopause Society of Surat from 2024 to 26. So currently, and President of Surat Obs and Gynae Society and President UMA 2022-24. Welcome, ma'am.
Thank you, Dr. Deepika. You may leave me move forward. Thank you so much.
Welcome, ma'am. Dr. Monica, आप introduce करेंगे?
Please show the CV of panelist also. Should I introduce the panelist?
हाँ जी, I think आप करो.
We have got an excellent galaxy of panelists. Dr. Vishank Patel. He's a master in reproductive medicine and IVF, with special interest in advanced laparoscopic surgery and infertility. He was All India first rank in ICOG laparoscopic course exam. Next.
Thank you for the
Dr. Kokila
introduction.
Desai, she is the president of Surat OBGY Society. Next. Dr. Milind Wadekar, he is a gynae laparoscopic surgeon, youngest to do diploma in gynae endoscopy at Kehl Hospital of Endoscopy at Germany. Next. Dr. Charu Johari, secretary, Alwar OBGY Society, fellow in ART, and received the gold medalist in DGO. Next. Dr. Indu Verma Sood, she is a professor and HOD of Department of OBGY, Alwar Medical College, and she is associated with Ludhiana Medical College also. Next. Next. Dr. Dadu, he has done the MBBS from BJ Medical College, and he is currently practicing as a private practitioner in Modasa. Next. Dr. Sapan Doshi, he is working in Tulip Hospital, and he is a secretary of Himmatnagar OBGY Society. Next.
Done, ma'am. All 8 panelists.
We have done with all the panelists, and over to you, sir, for the panel discussion.
I think my screen is visible to all.
Yes, sir.
Yes, sir.
Thank you. So we are going to discuss common
Yes.
topic, that is fever in the pregnancy.
We have Malla, we have not introduced Savita Lalgaria. She is also one of the panelists because the CV was not there. She is a secretary from Ganganagar OBGY Society.
Welcome, Dr.
Welcome, Savita.
Yeah, we have Dr. Vishang, Dr. Kokila ma'am, Dr. Milind, Dr. Zakir, Dr. Charu, Dr. Indu, Dr. Savita, and Dr. Sapan Doshi. Anyone can take any question at any time, and house is open for the discussion. We are going to discuss the common topic which needs everybody's input, how they are managing the cases. And as far as possible, we'll stick to the topic because we are going to cover all the diseases in this. Fever more than 38 degrees centigrade or more than 37.5 on 2 occasions, 2 hours apart, is called pyrexia. Why it is important to have pregnancy with fever, to take it seriously, because it's challenging as physiological changes make it more susceptible for severe infection. Pregnant women with febrile illness are more likely to have critical complication, increased heart rate, increased oxygen consumption, decreased lung capacity, and decreased cell-mediated immunity. Due to physiological changes, the limitation for diagnosis and treatment, clinical manifestation are same as general population, but first trimester she has nausea and vomiting, which masks the signs of infection. Second trimester, hypervolemia, low hematocrit, increased heart rate, low BP, general vasodilation makes severity of disease difficult to diagnose early. And the most important part is there can be a fetal compromise, and even we have seen so many intrauterine fetal death in cases where there was a fever or within 3 to 4 days after subsiding the fever also. So it's very important for us to discuss both maternal as well as fetal complications of fever in the pregnancy. So I'm going to go to Dr. Vishang. What are the common causes of fever in antepartum, intrapartum, and postpartum period? Dr. Vishang Patel. Dr. Vishang, you are there? Or Dr. Milind, you can take this?
Yes. So, of course, we can divide them, the kind of infections that we are talking about can be divided into what we call intrapartum, antepartum infections and the intrapartum infections. So, one of them can be the pneumonia, influenza, swine flu, or the commonest being malaria, typhoid, dengue, and gynecological causes, which can be chorioamnionitis or anything. Similarly, when we come to intrapartum,
Kira Desai, can you just mute, please? Yes, please.
So yeah, the intrapartum infections, of course, can be prolonged labor and other causes.
Right. Or there can be a physiological like dehydration. This can be the causes. And there are drugs like oxytocin and epidural analgesia might cause certain fevers. So now we are going to go to the first case, Mrs. XYZ, G4, P2, L1, A1 with 28 weeks pregnancy, history of 2 preterm deliveries, one died due to extreme, Dr. Vishang, welcome. Due to extreme prematurity, one born at 32 weeks was in NICU and now 2 years old. History of fever with chills and rigors, increased frequency of micturition since a week, burning since 2 days, uterus is relaxed, 28 weeks, os is closed, urine routine shows 70 pus cells and CBC shows leukocytosis of 17,000 per cubic millimeter. So, Dr. Visham, what are the investigation you are going to do for her? And what is, yes, please.
Urine routine microscopy is the first investigation, as she is already presented with the WBC count of 17,000. And I'll also go for the midstream urine culture sensitivity and also high vaginal swab for culture sensitivity.
Okay, so Dr. Visham, what is considered as
And
significant UTI in pregnancy? And how often you see in
the urinary
pregnancy
tract,
in practice?
many times we see the asymptomatic bacterial urea is very common in pregnancy. 10,000 organism per ml in 2 consecutive urine sample is called as a asymptomatic bacteriuria, and with the symptoms like fever, pain, lower abdomen, uh, it is a symptomatic bacteriuria, more than 100 organisms per ml.
Right. Yes, and you said about the culture and very rightly said midstream urine sample clean clutch is very important because there might be certain infection at the external urethra, so that can be tackled out this. So positive culture is 2 consecutive audit specimens with isolation of some of the bacterial strains and colony count of 1 lakh CFU per ml or higher. So Dr. Charu ma'am, what is acute cystitis and acute pyelonephritis? Is it common in pregnancy? And what are the risk factors who are more susceptible to have UTI in pregnancy?
Good evening, all. Thank you for the question. And acute cystitis means there is an infection which is going to the bladder. Also means infection in the bladder. So it occurs at around 1% of the pregnant women, and pyelonephritis is around occurs in the 2% of untreated UTI cases. So it's very important to treat all the UTI cases in all the pregnant women. And you asked about the causes, symptoms also.
What are the
In
risk
acute
factors for?
cystitis, acute cystitis, there will be suprapubic pain, dysuria, burning micturition, and in pyelonephritis there will be pain in the upper
Lumbar
area
region.
also, and lumbar area, and acute along with fever, with chills, and like dysuria, burning micturition also will be there, but more of toxic look, and more of pain in the lumbar area, and the common causes, you are asking for common causes also, right?
Right, ma'am.
So causes of UTI, like because in the pregnant patients, because of progesterone, there is the effect of progesterone is there, and urinary stasis will be there, and more of urinary retention sometimes because of pressure of the enlarged uterus to the bladder. It also called retention of the urine, and the tone of the urethral tone is also lost because of these hormones, and difficult to maintain hygiene as well. So all this leads to more prone to infections, and sometimes patients do not drink proper water, and dehydration also leads to UTI problems in pregnant women.
Yes, very rightly said by Dr. Charu. Now coming to Dr. Kokila, madam, which are the organisms which cause UTI in pregnancy?
Normally, when you do culture sensitivity, gram negative is more commonly found in UTI. And sometimes in cases of resistance UTI, you can see the E. coli. And culture sensitivity is very important for diagnosing this and managing these patients, because you cannot give an antibiotic randomly in these patients.
Rightly said. So symptoms like dysuria, whenever there is a fever, suprapubic pain, you need to do a culture sensitivity.
Yeah, and CRP also sometimes helps. Sometimes culture comes negative. In that case, if you have done a CBC with CRP, that can help you to rule out the undiagnosed by culture sensitivity.
Yes, Dr. Savita Lalgaria, why we are worried about the pregnancy outcomes of UTI?
Because, sir, it can spread infection to upwards like kidney, and it can harm to baby also. It can cause preterm birth, low birth with baby, and increase
and
perinatal
PRO.
mortality. Yes.
Very rightly said by madam that the fetal complications like preterm labor, low birth weight, and even mortality and morbidity is more in these patients. Dr. Kokila, madam, would you like to admit each and every patient, or you have some different criteria for admission?
Basically, I would like to treat the patients on OPD base if this patient's uterus was relaxed. So if there
Right.
is no patient has no symptoms of pain, uterus is relaxed, and if I see, I think it's only twice or thrice the fever is there, and it is subsiding with the paracetamol, means going down, then I would at least treat her on OPD basis. And my first drug of choice will be cefuroxime, normally if culture has not come. And once the culture is come, the report has come, then according to the culture sensitivity report, I will choose the antibiotic. But if the patient comes with the symptoms of pain in abdomen and uterus is irritable, and if the fever is not subsiding or the spikes are going more frequently, then I would like to admit her and would like to start with the injectable antibiotic along with other injectable infusions.
Very rightly said, ma'am. Dr. Sapan, are you there?
Yeah, he's there.
Yes,
He's there.
sir.
Yes, yes. So, Dr. Indu Verma, can you just unmute, please? What are the
Yes.
UTI
Yes,
management
yes, sir.
guidelines? Right.
Yes,
What
sir.
are the UTI management guidelines in pregnancy, ma'am?
As the UTI is a very common complication, commonest medical complication you can say during pregnancy. So we have to screen all the pregnant women at least once between 12 to 14 or 16 weeks of pregnancy for asymptomatic bacteria with a midstream urine culture. As most of the patients, they will be asymptomatic. So we have to do a culture sensitivity test, and diagnosis can be made if we find a high level of bacterial growth that is more than 10 raised to power 5 of colony forming units per ml, and in the absence of any other symptoms, that will be for asymptomatic bacteria, then we have to treat the patient according to the sensitivity using nitrofurantoin, beta lactams or phosphomycin. And a routine follow-up culture is not required after treatment of the asymptomatic bacteria.
Very right. Dr. Sapan, what are the patients, what is the parental regime for empirical treatment of pyelonephritis in pregnancy, where patient has fever, signs of lumbar pain, and patient
So,
is toxic?
so we
Yes.
can start with empirical antibiotic therapy like beta-lactam or nitrofurantoin according the severity of symptom. Then secondly, if patient is having pain and uterus is relaxed, then we can add up with drotaverine or dicyclomine. And if uterus is irritable a bit, then we can add isoxsuprine also. And then rest is symptomatic management with paracetamol for fever, and rest whatever symptom we can treat. If
Yeah.
the fever spikes are not controlled with oral paracetamol and uterus is irritable, then we might need to admit her and then start with injectable antibiotic till the culture report comes, and then according to culture we can add antibiotic again.
Like ceftriaxone.
Yes, very rightly said by Dr. Sapan. Now coming to our expert.
We can keep this phosphomycin as a reserve drug, not at first line of treatment.
Yeah. So coming to Dr. Jagruti Desai, can you just summarize about this case of UTI in pregnancy, ma'am?
Yes, so first and foremost, go for all women in pregnancy. We should screen for asymptomatic bacteria. And whenever there are symptoms of bladder, of pain in suprapubic region, or symptoms of dysuria, burning micturition, and so on, go for urine routine microscopy, urine culture sensitivity, and accordingly, we can prescribe treat her on OPD basis, or admit her and treat her. One thing I would like to add is avoid certain drugs, avoid in first time, we have to be specific. which is to be used in which trimester, first, second, and third trimester. And another thing I would also like to add that we may go for ultrasonography of the whole abdomen. That is, many a times this urinary tract infection are associated with renal calculus or an ureteric calculus or a bladder calculus. And many a times, because of the pressure of the enlarged uterus, patient may be having back pressure, hydronephrosis, and sometimes if the very severe infections and patient is going for acute pyelonephritis, ultrasonography will always helpful. So add ultrasonography also in your routine test. And
Yes,
avoid nitrofurantoin in first trimester of pregnancy. And fluoroquinolones, that also should be avoided, right?
Yes, ma'am. So rightly said by madam, ultrasound is going to give you idea about the pyelonephritis. Whenever there is fever, please document ultrasound. That will help in two ways. Firstly, knowing the kidney damage, and secondly, very important for the fetal heart rate documentation. That is very important. And whenever you are going to discharge the patient, that time also you can document on ultrasound the FHS, or on NST she can be heard about the FHR. Now coming to the case number 2, to my friend Dr. Jakir. Mrs. ABC, primary with 20 weeks pregnancy, living in slum area, has high grade of fever with chills and rigor since 3 days, looks pale and little icterus, plus last week husband and mother-in-law had malaria and dengue respectively in the family. What do you suspect and what will be your plan of investigation and treatment? Dr. Jakir Dadu. Zakir bhai. Dr. Milind, can you take this? Unmute karo.
Milind sir, please unmute.
Hello, yeah. So yes, the very classical case, high-grade fever with chills and rigors, and then followed by, of course, a history of malaria. Especially when it is getting icteric and all, we do suspect either malaria or dengue in this particular case. And of course, you'll be doing simple investigation with peripheral smear, which would of course be considered the gold standard. And then you can also usually start doing the rapid diagnostic tests, which are sensitive for HRP2 and that PLDH. Along with that, we try to find out if whether we said the patient is icteric. So what is the level of liver function tests, serum creatinine, and other tests. So yes, that would be very helpful. And once you come to a diagnosis, the commonest falciparum malaria, Vivax, which are common, and accordingly we need to start thinking.
Dr. Indu Verma, why you are worried about malaria and pregnancy? Dr. Milind has very rightly said about the falciparum, Vivax, and these diseases in pregnancy. And even in this case, it has come to a level of icterus. So some part of the liver is getting damaged. So why it is important to
because as such it will malaria will have a grave consequences on the fetal as well as on the mother. And for the fetus, the placenta is affected, and the intervillous spaces, they become blocked with macrophages and parasites, and there's diminished blood flow to the fetus. Ultimately, it can affect the blood flow, and it can cause IUD and fetal distress. And also in the non-endemic areas, congenital malaria is not uncommon. But pregnant women living in the endemic areas, they have antibodies. Antibodies are transferred to the baby. So the congenital malaria is not common. But in non-endemic areas, it is more common. And effects like complications can occur in the mother because of the anemia. Is due to the hemolysis. Hemolysis is occurring, it will lead to anemia, hypoglycemia, dehydration. Then the jaundice, and patient can go into acute renal failure, pulmonary edema, respiratory distress, and sometimes convulsions and DIC. And so that's why, and the complications are grave. So that's why we have to think very seriously. If any pregnant lady is having malaria, especially the falciparum, we had to admit the patient in the ICU setting and manage her with proper hydration, decreasing her fever, giving supporting treatment, and giving her antimalarials.
Very rightly said by Dr. Indu Verma. She has categorized into maternal and fetal complication like maternal anemia, cerebral malaria, severe malaria. There can be maternal morbidity or even mortality. She has covered all DIC and everything. And child outcomes like abortion, stillbirth, preterm delivery, low birth weight babies, neonatal mortality, and poor development and behavioral outcome can be there. So coming to Dr. Charu Johri, ma'am, what are the treatment options in malaria? And does it change according to the trimester, that is first trimester, second trimester, or third trimester?
Yes, the treatment options will change according to the trimester of pregnancy. In the first trimester, the chloroquines and the quinine is safe. And in the second line management, we can also add artesunate or arteether also. But in second or third trimester, it's better to use pyrimethamine plus sulfadoxine, or we can use mefloquines also. So these are the drugs, and we should give doxycycline or fluoroquinolones very cautiously in pregnancy, because it will affect the fetus also. So, and it depends on the severity, because we can give, if required, we can give IV also, like quinine we can give IV, and chloroquine we have to give orally, but the dose is like starting from 600 milligram start dose, later on 300 milligram after 6 hours, 24 hours and 48 hours. And likewise quinine we can give IV infusions also. Artesunate we can give either oral or IV both. And pyrimethamine we have to give 3 tablets in single dose. This depends on the trimester of pregnancy and the severity, whether we have to go for oral or we have to go directly on the IV medicines.
Very rightly said by Dr. Charu Johri that in the first trimester, chloroquine or quinine are the drugs of choice. Second line, every time it can be artesunate, artemether, or arteether can be used. And second trimester, pyrimethamine and sulfa. And if there is a falciparum, mefloquine can be used for these patients. Now coming to Dr. Kokila Desai, what are the challenges we face and we need to be careful with whenever in case of malaria?
Malaria and dengue, like sometimes the fever pattern is mimicking. So it's very important to rule out dengue and other causes. And after that, like if a patient is suffering from malaria, the secondary complications like meningitis and spread of the anaerobic environment is very important. And here, as such, it is showing the jaundice positive. That means there is an involvement of the liver. So in such cases, we have to be very careful. And if in these patients, we should go for the LFT. We have to monitor her jaundice and liver profile also. Because if that deteriorates, the patient may develop hepatocellular, hepatorenal upset, and that complication can take place. So it's better if such symptoms are present, that patient should be treated in an ICU area where the ICU facility is available. So if any complication arise in between while treating this patient, we can directly shift the patient to the ICU. And I normally, personally, I always prefer to involve the physician. So whenever I'm treating a medical illness, I always involve the physician, so that other opinion can also be like what we are missing, we can that can guide us. And in malaria also, we have seen like the pattern of the patient's symptoms are changing in a different seasons, and different medicines works better way. So normally when we involve the physician, they knows like at this season, in especially in endemic areas, which medicines are very effective, and so they usually guide us. And we have to be very careful about monitoring the DIC complications, like if there is a platelet going down, or if there is a over infusion has been done, and if there is some pulmonary edema develops. So that has to be kept in mind, and not the over infusion should not be given.
Very rightly said by Dr. Desai that don't waste any time whenever there is a liver or kidney affection. It is always better to admit such patients, assess the severity, monitor the maternal and fetal vital parameters, involve a physician, and as far as possible in a physician setting, you admit this patient, because sometimes it can be very toxic that in the night patient gets spike and you are you have a busy day and you might be not taking care. So avoid overdrugging or underdosing of the drugs, avoid fluid overload or even dehydration. Maintain adequate intake of calories that can be done in a multi-speciality setups. Very rightly said, Dr. Kokela Desai. Thank you for this. Now coming to, sorry, Dr. Vishang, how to manage labor in the pregnant patient with malaria?
So malaria has drastic complication in the third trimester. Many patients we see with pulse-failure malaria, they come with preterm labor pain, and also the fetal distress is very common. So all efforts should be made to rapidly bring the temperature down by sponging and antibiotics or the IV paracetamol. Also, the severe falciparum malaria in term pregnancy carries a very high mortality. So the pregnant women with severe malaria are better managed in the ICU setup.
Yeah, multidisciplinary setup, it is always better, and you can go there and deliver this patient. And also frequency and intensity of contraction appear to be related to the height of the fever. Fetal distress is common and it is often unrecognized. So you have to get your NHT machine in the setup of ICU and go there and deliver. And as far as possible, you are rightly said, tepid sponging, antipyretics are going to be very important. Careful fluid management, prevention of the dehydration as well as fluid overload. And in case of very high paracytemia, exchange transfusion can be done. If the such situation demands, induction of labor may have to be considered. Once the patient is labor, fetal or maternal distress may indicate need of shortening of the second stage for forceps or vacuum. If needed, even cesarean section must be considered. Whenever there is a jaundice, you have to be very careful about the cesarean section. As far as possible, you do a counseling of the patient and do a FTND or normal delivery as far as the possible. Very rightly said, sir. Thank you. Dr. Sapan Doshi, dengue in the pregnancy, it mimics the same way, except any differences,
Management.
clinical features?
Hello. Yeah. So in dengue, we can go with dengue testing by NS1 antigen, and so diagnosis can be made. There are other feature like there will be a continuous high grade fever. Then there will be a thrombocytopenia, so that there will be a hemorrhagic tendency which show by petechial hemorrhage or epistaxis. Then there will be a third space collection like pleural effusion or ascites or like that symptom. So we can diagnose malaria and dengue easily with this kind of investigation and then symptom.
Right. And there are obstetric complications which are similar to malaria, like miscarriage, preterm birth, and that can be managed. But here important, as you are rightly said, is about the hemorrhagic tendency, which needs to be again a multi-specialty involvement of the doctors is very important while you are managing such patients. And what are the investigations as they to be done at particular time? When is NSI to be done? When does IgM become positive? You have any idea, Dr. Sapan, about this?
NS1 antigen done as a primary testing, and then we can use IgM antibody by that reagent strip method, or if needed, then we can go for PCR, which is almost 95% specificity.
Yes, thank you, Dr. Sapan. Now coming to Dr. Savita Lalgaria,
Yes,
what is
thank
the
you.
management of dengue for antenatal and a patient in labor? How you are going to manage this?
Yeah, first we are going to admit this patient, and as patient is suffering from high grade fever, so we have to give him paracetamol drips and IV fluids accordingly to treat dehydration as well as to prevent overdoses of the fluid. And we have to start broad spectrum antibiotics also to prevent superimposed any infection. And if platelets are down, HB is low, then we have to transfuse blood also, sir. Blood products can be given with after cross matching, and we have to monitor maternal vital parameters according to, and fetal parameters also, fetal heart rate we have to see. And if patient is in labor, we have to prevent any trauma or injury, and active management third stage has to be done. We don't wait for blood loss. Like carbetocin we can inject in this patient IV for prevention, and vitamin K can be given, and transfusion of platelets can be considered if platelets are very low.
Very rightly said, madam. So trauma as far as possible to be minimal or avoided, like episiotomy, whatever is required, transfusion of platelet concentration during or at the time of delivery, but not too late, and do not wait for hematocrit to decrease to low levels. Now, again, coming back to our expert, madam, how you are going to cover?
So, in case of fever, like early diagnosis is very important. One may repeat the smear twice a day, and the platelets will obviously go down in dengue fever and as low as 20,000. So, there is no need for platelet transfusion in these cases if the dengue fever is confirmed. Only if you are going for any delivery or cesarean section or something, operative procedure, then only you need to give platelet transfusion. So
So
that
what
is
is
very
the
important.
cutoff for cesarean, and what is cutoff for the normal delivery, madam?
Yeah, 50,000 for cesarean section and 75,000, 50,000 for cesarean section. That
Yes,
is the cutoff.
And 20,000 for normal delivery.
Normal delivery, right?
Right. Very rightly said by Dr. Jagruti Desai. You have to have a multidisciplinary approach, always involve a physician. Please talk to the relatives and patient, give confidence to the patient, and counseling of the relatives is very important. Now, coming to the case number 3, Mrs. ABC, unmarried, primigravida with history of 5 months amenorrhea, fever with chills and rigors, toxic looking, and some intervention done by some GP, transferred from private small nursing home, evidence of foul smelling vaginal discharge, hemoglobin has dropped down to 7, counts 21,000, tachycardia of 150, falling BP 90/60, looks to be in a frank sepsis. So what is the likely diagnosis, Dr. Kokila Desai?
So basically, she has a 5 months of amenorrhea. So probably it can be a septic abortion or can be a MTP. Whether she has undergone MTP, does she give any history of gave a history?
No history, ma'am. She's transferred from a small hospital.
Yes. Because she's unmarried and she may have become pregnant and she may have hidden that things with the physician and she may ended up with a septic abortion. That is the first most likely possibility because having a vaginal discharge and as her pulse is going down, BP is down, suggestive of septic shock. So entering in a septic shock. So basically, these patients requires admission directly, and then investigations for the septicemia, the source of the primary source of septic. Sepsis is also required. So we require the blood investigations, sonography, admissions, IV fluids, and again a multidisciplinary approach with involving the physician to find out like what the line of management.
Thank you so much, ma'am. Dr. Milind Wadekar, is there any grading for septic abortion or uterine sepsis? And how you're going to decide your plan of action depending on this grading system?
So, number one, you can devise in 3 grades, depending upon whether it is up to the uterus only or a little beyond the uterus, that is the parametrium tubes or the ovaries or pelvic, up to the pelvic. And if there is generalized peritonitis or endotoxic shock, then probably leading to acute renal failure, then probably you need to consider it as grade 3. And yes, basically what in either case, I feel we need to be very, very aggressive when it comes to management of septic abortions, because I think I would always admit these patients, start them on IV, and if they are in grade 3, of course, they would require an ICU care.
And Dr. Milind, it's very important to admit this patient and deliver them as far as possible. Remove the bits of placenta, remove the fetus, whichever is required, because that is how it is going to lower the load from the uterine cavity. So that is going to be really important. And the report of culture, sensitivity, everything will be start coming. It might take 2 to 3 days. Till that time, you start aggressively. So, Dr. Milind, how are you going to what are the tests which are going to tell you about the severity of this patient? That is,
So we would like to know whether the patient has actually gone into DIC or renal failure.
Very right.
Point. So you might get the fibrinogen levels or the blood and D-dimer levels, renal function tests, the X-rays, and the sonography. And of course,
the role of sonography here, Dr. Milind?
So basically, we need to know how much is involved. See that in septic abortions, the causes can be even somebody trying to even rupture the uterus or something like that, and could have even damaged the bowel too. So I mean, of course, also we need to know how much is there in the uterus. Is it complete? Is it incomplete? So a lot of factors will come to know from the sonography too.
Very rightly said about Dr. Milind, because he has managed so many cases like this in his PG days. He knows that ultrasound is going to help you to know about the status of the disease, whether there are any iatrogenic complication has been there, whether there is any pus in the pouch of Douglas, and all other things. Fluid in the peritoneal cavity is going to give, and then accordingly he is going to manage, and the treatment has to be planned like that after this.
Any foreign body, presence of any foreign body
Right.
also?
Yes, any POCs, any foreign bodies, that is very important. So now Dr. Indu Verma or Dr. Charu can take this. What is the surgical management in such cases?
Basically, we have to admit her and start her on broad spectrum antibiotics. We'll give her triple antibiotics, injectable, ampicillin, metronidazole, and Genta. Then we have to continue with the antibiotics for at least 48 hours. And once she's under the coverage of antibiotics for 48 hours at least, and she becomes afebrile and or coverage of antibiotics, then we have to evacuate the uterus. So manual vacuum aspiration method is preferred method. And otherwise we can do the dilatation and curettage. And sometime to drain the pus collected in the abdominal cavity in the pelvis, we have to do posterior colpotomy so that drainage of the pus is there. And sometimes we have to resort to laparotomy also. If there are a lot of adhesions and if the peritoneal cavity is full with pus and she's having peritonitis and the condition is very sick. And sometimes rarely we have to do hysterectomy, life-saving hysterectomy. If there's like damage, traumatic injury to the uterus, and the uterus is like totally septic, and as a life-saving procedure to save the life, we have to remove the focus of the infection.
Very rightly said by Dr. Indu. The important is focus. If patient is very toxic, then you might not wait for 48 hours also. You can start your management as early as possible. But if your patient is going to be not that toxic, then it is always better to do any procedure under triple antibiotics, because that is going to be a big role in management. Before going to Dr. Jagruti, we'll finish off this case also, because it is a similar case. And at the end of this, Dr. Jagruti Desai will tell us about the case 3 as well as case 4. Now coming to this case where Mrs. XYZ, G6P5L5 with leaking PV since 3 days, full term, high-grade fever with foul-smelling vaginal discharge with absent FSH, that is IUD. And what does this case looks like, and what are the clinical features, risk factors for the mother and the fetus? Now this question is for Dr. Charu Johri.
Dr. Jakir has also joined.
Oh, Dr. Jakir Dadu, after will take his opinion in the second part. Dr. Charu will take the question.
Yeah, thank you. This looks like a case of chorioamnionitis, where there is a history of leaking, associated foul discharge, and the FHS is absent because of probably the infection present from the fetal membranes to the fetus. and the bacteria basically will ascend from the membranes, vagina to the membranes, and it occurs in around 50 to 70% of the cases where there is a history of prolonged labor or PPROM. And the organism may be like uroplasma, uroliticum, mycoplasma, or there may be Gardnerella vaginalis also, or group B streptococcus. Clinical features, as mentioned in this case, also the history of leaking, fever, and there will be uterine tenderness or fundal tenderness present. Maternal fever, maternal tachycardia. If baby is alive, there will be fetal tachycardia also present. And in these cases, because we are dealing with chorioamnionitis, we have to do investigations like CBC. The leaking is present, so we have to go for amniotic fluid culture sensitivity and high vaginal swab culture sensitivity also. And risk factors like preterm labor or prolonged labor and premature rupture of membranes. In such cases, there is this increased risk factor if there is an immunocompromised patient, or there is a history of bacterial vaginosis, or multiple vaginal examinations for the patient, or if there is a history of epidural anesthesia, that also may lead to, this is also a risk factor for such cases.
And patient may be immunocompromised per se, like
Immunocompromised, yes.
something like that. Now coming to Dr. Zakir Dadu, welcome Dr. Zakir. What are the maternal as well as fetal complications in such patients? Dr. Zakir.
Yes, sir. Yes.
Yes, boss. आ गए आप?
Yes. Yes.
So what are the maternal and fetal complication in case of chorioamnionitis?
First of all, sir, in this patient, most of the bacteremia, then as well as a pelvic infection, and also patient present with septic shock, and a patient may go to DIC, and as well as maternal mortality.
Very high risk for maternal mortality, right? Fetal complications?
Fetal IUFD, yeah, mean pneumonia, septic shock, or early onset of neonatal sepsis.
Yeah, birth asphyxia, pneumonia, intracerebral hemorrhage. Now, very rightly said. What are the management basics to be kept in mind, Dr. Zakir, while you are going to manage such patient of chorioamnionitis?
First, we admit the patient and give a broad spectrum antibiotic, and if a patient present with the active labor, then induce the labor, and if very high, means septic shock, then go directly with cesarean section.
Under cover of the good antibiotics, right?
Broad spectrum antibiotic.
As far as possible, if cervix is favorable, then do induction of labor.
Induction of the labor.
It is going to be always better because you are not going to open the abdominal cavity if there is already infection in the uterus. So to summarize, it can have infective focus from bacteria, which can cause chorioamnionitis, septic, abortion, viral, and iatrogenic, like ambient temperature of the lower room, labor, epidural anesthesia, and non-pregnancy related complication like UTI, cholestasis, HIV, herpes, rubella. These drugs can call out this. So now coming to our expert about these two cases, madam.
Yes, so fever in pregnancy are red flags for the mother and the fetus. So always investigate early. For first and foremost, we go for a complete blood count and the peripheral smear. And whenever the total count is high and you are suspecting sepsis, go for blood culture, identify the organism, and give her the specific antibiotics. Secondly, always treat the patient basically, that is ABC, resuscitate, stabilize her with IV fluids. And if there are any less of platelets or blood products are necessary, then transfuse her with blood products also. These patients very frequently go in septic shock syndrome and in DIC, and multi-organ failure is also common. So involve all the specialties also, and multidisciplinary treatment is always necessary, and take care of other electrolytes, creatinine, urea, other bilirubin and liver function tests. All these tests should also be done whenever the patient is in septic shock, if she goes for septic shock.
Yes, ma'am. And Dr. Kokila, this is last word from you. This patient you have managed very well. Now she's fine. Again, she comes to you after 6 months with UPT positive. What are the things you are going to do, and what diet advice you are going to tell her so that she should not go into a sepsis in the next pregnancy?
See, she conceived naturally within a 6 month. It's actually very good thing. Otherwise, these patients may end up with infertility once they develop the sepsis. And second thing is she had already IVFD, so we allowed her to become pregnant. And depending upon the cesarean, we have to tell her like she has to be very careful in the last trimester for the taking care that she should not come late. And the most important thing during the pregnancy, she should be screened for the UTI, what we discussed in the first patients, like culture of the urine. So asymptomatic
Local
bacteria has
hygiene.
to be,
Yes,
local hygiene should be
symptomatic
taken
bacteria,
care of. Yes. And
high
throughout
protein
the
diet.
pregnancy, she has to take care of that she should not develop infection in any other part of the body. And if she's immunocompromised, or if she is on some certain drugs, because of that she has become immunocompromised, then she should go for frequent checkup to rule out the infection. And in the last thing is probably if she has come develop chorioamnionitis due to the PROM, then we have to make her alert about the PROM also and preterm labor also, that she may likely to develop preterm labor this time also. And for prevention of PROM, we have to do the high vaginal swab and culture sensitivity test even in each trimester to rule out the infections.
Thank you, ma'am. Giving good diet, good care, personalized
Yes.
hygiene is very important for such patients.
And I can add something. We can do the screening for bacterial vaginosis also.
Right.
Yes.
Do the
high vaginal swab.
yes,
Yeah, that's the
screening
high
for
vaginal
bacterial
swab.
vaginosis specifically, and also the high vaginal swab for beta
Swabs.
streptococcus also.
Yes.
That is a cause of like sepsis and neonatal sepsis also.
Yes.
Thank you, everyone.
And also control her sugars and do the sugar
Yeah,
testing
if-
is also
yeah.
important, and also doing the OGTT test whether to
Yes.
she's diabetic or not,
Just
and to
rule out,
control her
yes.
sugars also besides hygiene. And also I think we have to screen for other STDs also, because they also make the patient more prone for any acquired infections,
Right.
any STDs and reproductive tract infection. Other also they make more prone for such complications. We have to screen for them also.
Dr. Visham, what is role of doing OGTT, and at what weeks of gestation you plan to do OGTT in all pregnant patients? Dr. Visham is there? Or Dr. Savita Lalgaria can take this? Dr. Savita, ma'am?
You are muted. Unmute, please. Yeah.
Yes. OGT test, sir, we are doing in all pregnancy patients, in high risk patients in first visit. Otherwise, in second trimester, we have to do in all patients.
So all high-risk patient or BMI more than 25, you are doing at first
First
visit.
visit, yes.
And Dr. Milind, what is your criteria? You are doing at 28 weeks or routinely?
So what I do is
Routinely.
as a routine screening, a routine blood sugar is done even in the first trimester. But I do a DIPSI test at around 24 weeks of pregnancy.
24. Dr. Sab, what is your protocol?
So we do routine OGTT after Tifasquent till 28 week. So
Yeah,
around 22 to 28 week we do it.
So nowadays, because late marriages, age is more, even BMI is more, patients are high-risk patient, IVF pregnancy is always mandatory to between 24 to 28 weeks of gestation. That is a take-home message for this case. Now coming to the case number, Dr. Jagruti ma'am, you can add.
Yes, many a times there are indications on sonography also when you are going for serial sonography. If there is excessive liquor or if the baby size is more, then also you have to repeat in spite of doing it 24 weeks or 28 weeks. Many a times we have to repeat earlier. And
Ma'am, according to the
24 weeks
guidelines, it is
also.
recommended at the first visit. We have to do it at the first visit of the patient and again repeat between 24 to 28 weeks.
Yes, that is all right.
We
That's
have to do
fine.
it
That is,
always. First
yes,
visit and again repeat at 24 to 28 weeks.
Ma'am,
yes,
in the high risk cases, we have to repeat in the third trimester also.
and Mr. Also,
Yeah.
I want to add that.
We cannot wait till 28 weeks for the first test.
No. I mean to say is even after doing it
She was
first
saying
trimester,
about the
second
ultrasound
trimester,
report
we have
showing
again to repeat in
polyhydramnios.
third trimester.
We
now-
don't have to wait for the ultrasound, ma'am. First visit may we'll do the OGTD in the first trimester, then repeat at 24 to 28
That is, we are
weeks.
saying
Dr.
ki
Indu,
that
she was saying that if in case there is a polyhydramnios in any of the scans, she will advise again. That's what Dr.
Yes.
Jagruti was.
Yes.
Just wanted to add on, yeah.
Yeah.
We
Dr.
get it
Sapan,
done.
Okay.
now case number 5. Mrs. AB, primary with 30 weeks with fever since 3 days. With cough and cold, blocked nose, sputum is clear, fever is high grade, and she looks breathless. This is a very common scenario nowadays after rainy season. So, Dr. Sapan Doshi, how are you going to manage this patient?
So, these are the symptoms look like upper respiratory tract involvement. So, we can screen for URTI, and we most common infection are viral infection. So, most of the time it is a self-limiting. But if superimposed with the bacterial infection, then we need to investigate more with CBC, CRP, if needed, then HRCT, and then nasal swab.
Yeah, depending on the severity. Otherwise, you
Severity.
have to look for rhinorrhea, sore throat, headache is very important, cough, ear pain, then you're going to, and there was our big friend of COVID-19, so their test, it was very common.
Symptomatic treatment.
Yeah, symptomatic treatment is very important.
Yes.
And
CB
influenza.
Yes, influenza virus test.
Influenza virus.
Right. So treatment is symptomatic again, cough suppressant, antihistaminics. If require antibiotics, 2 are possible, cephalosporin, azithromycin. She has to take a lot of fluid intake. And this is the summary of any of the viral infection. Acute localized infection, just symptomatic, acute undifferentiated febrile illness. There can be malarial, non-malarial. It can be viral, bacterial, or parasitic infection can be taken out. So differential diagnosis in fever during pregnancy is dysuria, cystitis, foul-smelling discharge, septic abortion, headache, muscle pain, anemia, coma, uncomplicated malaria, cough with expectoration, pneumonia, dry cough, malaise, anorexia, typhoid, malaise, anorexia, nausea, or dark urine, pale stool, jaundice, hepatitis. So these are the things which need to be there in your mind whenever you are treating any patient with fever. So coming to our expert for final comments on the last slide.
Yes, so timely every fever in pregnancy is a potential emergency, and timely evaluation and target therapy has to be given to save both the mother and the fetus. And all medications, they should be trimester specific. Fetal monitoring is also important by NST, regular NSTs, and ultrasonography. And whenever necessary, one has to think of induction of labor, by which route, that is also very essential. And serially, you have to monitor the patient accurately during all trimesters. And a multidisciplinary care is always essential whenever a complicated patient of pregnancy and fever comes to us.
Thank you, Dr. Jagruti Desai, for your inputs. Now I'm going to go to each panelist for one word of wisdom in fever in pregnancy. Don't repeat it. Dr. Milind.
That was sudden. Okay, so for
Anything you can say.
fever, I would say I would always be very, very vigilant for any fever in pregnancy, and I don't think they should be taken very lightly.
Thank you. Dr. Indu.
Sir, I would like to say fever in pregnancy, we cannot just ignore it. We have to take a proper history. And even if she's just come with simple symptoms of URI and running nose, we have to take the proper history and rule out any significant causes of fever or any other thing, and reach a differential diagnosis or diagnosis right there only and start the treatment. And also, like we can take the medical opinion.
That's it. Dr. Kokila Desai.
Any patients of fever with pregnancy cannot be taken lightly. So I'll always think of feto-maternal complications of the that fever, and diagnosis is very important to pinpoint which organ has been involved, so that it can guide you about the feto-maternal complication pertaining to the disease.
Dr. Charu Jori. Dr. Charu, you have to unmute, please.
Like everyone is saying, we should deal fever very carefully, and if required, we have to involve other specialties also. We should not hesitate in involving others also on time.
Multidisciplinary approach. Right, very rightly said. Dr. Savita Lalgaria.
Yeah, proper in examination, then pinpoint diagnosis and proper care, and totally vigilant. Don't ignore.
Dr. Vishang.
Be aggressive, sir, in the diagnosis and treat the patient's symptoms, cure the symptoms. Feto-maternal life is at the stake.
Dr. Sapan Doshi.
Just reassure the patient that we are there with you, so don't be panic, and proper hydration and diagnosis would suffice, and we will take care of everything. So that should be understood, that we should not make patient panic.
Thank you, Dr. All panelists. And last word from Dr. Jagruti Desai, who is our expert.
Yes, we should always also take care that the patient is not over-treated. Unnecessary use of antibiotics should also be not there. Because many a times patient always comes ki mane tav jevu lage, like I am having fever, or every night I have fever, my hands are warm, and so I advise them, you buy a thermometer and
Very
keep
right.
a temperature record. So that will be more useful and more cheaper than taking other antibiotics and going to the doctor. So monitor your own temperature daily. So that is, I would like to add.
Thank you, our expert, Dr. Jagruti Desai. I'm really thankful to Dr. Vishang Patel, sir, Dr. Kokila Desai, Dr. Milind Wadekar, Dr. Charu Johri, Dr. Indu Verma, Dr. Savita Lalgaria, Dr. Sapan Doshi, and Dr. Jakir Dadu for their active involvement in this panel. And it was so interactive. And we are managing all these cases in day and day out. The patients which are chorioamnionitis, septic abortion are the patient where multidisciplinary approach is required. Otherwise, all cases we can manage it nicely. Only remember that fetal part has to be very carefully tackled. There are medico-legal complications because of not doing ultrasound at the time of discharge, and patient can come after 4-5 days with IUD. So we have to be really vigilant about these symptoms of fetal surveillance. Also, that is very important. I'm really thankful to Dr. Monica Gupta. Dr. Kazi, I'll just come to you in 1 second. And Dr. Deepika Logani for helping me for this webinar. And Dr. Monica Umbardhan and whole team of Corona Remedies for all the help, and all the chairperson seniors like Dr. Veena Madam is waiting, Dr. Sarita Madam is waiting till the end. We are really grateful to you because of inputs like seniors like you. We are progressing our field, and we are student till the last day of our lives. So thankful to Dr. Veena Ma'am and Dr. Sarita Ma'am for being there till the panel is over. And over to Dr. Kazi.
Sir, thank you very much. First of all, to take the topic, the commonest topic which we are encountered in our day-to-day practice, and I am totally agree with you that pyrexia can kill the fetus. I have encountered 2 IUDs in my private practice just because of the pyrexia, just because of the high temperature, and your detailed analysis on the pyrexia in pregnancy. This is the important topic which is helping us to understand not only the diagnostic challenges but also the delicate balance in managing maternal and fetal well-being. this is the important topic to be discussed with the routine consultants. And I, on behalf of all Gujarat, supporting you for your candidature. We all are with you, sir, and we are hoping for your vice presidency.
Based on.
Thank you, sir. Thank you for that.
I just want to add one thing.
Yes, Dr.
We have
Monica.
to tell our patient don't take fever lightly, because most
Yeah.
of the patients are taking paracetamol on their own. Ki, madam, I was like little bit feverish. It can be a viral fever. It can affect your baby, but they just simple take the paracetamol for 2 or 3 days. Nee, madam, I take the paracetamol and I'm okay. So we have to educate our patient ki never take fever lightly. It can affect you as well as your baby. Many times you may have the mild symptoms, but it can affect to your baby like anything. It can lead to congenital anomalies also. It can lead to death of your fetus also. That is very important. And I thank you, Kalyan sir, for organizing such a good program. And he's going for the vice president election this year, and he needs vote and support from everyone. Thank you, Ganganagar Society, Alwar Society, Himmat Nagar, and the Surat Societies, their chairpersons, their president and secretaries for joining, their members. And we look forward to see such events later on in the coming year also, when the sir is become vice president. Thank you, everyone. And I request for Dr. Kaji also. He's also going for the chairperson elections. So please,
Thank you, Doctor.
him also.
Yeah.
Yes.
Thank you very much.
Very
And
nice
we have-
discussion. Yeah.
Wishing you all the best, Dr. Kalyan sir and Dr. Kazi.
Yeah, the wonderful discussions and very informative, very nice discussion, very interactive session. And you have discussed every point. I must congratulate you the way you discussed the panelists and the most important thing is Monica is telling awareness about the fever is very important in pregnant women. You should not take that lightly. Any fever in pregnancy should take seriously, whether it is a simple or the we should screen only for the rule out the problems. So that is the most important thing. Dr. Jagrati, good evening very much.
Yeah,
And
good evening,
after
madam.
such a long time, I see you
Yes.
on the webinar. And I'm so happy to see you on the very good evening to Dr. Jagrati. Thank you so much.
Thank you, madam. Thank you so much.
Dr.
Yeah,
Sarita
one
ma'am,
more thing
words?
about vaccination.
Yeah.
We should also advise about vaccination in pregnancy.
Influenza
Yeah.
vaccine, yeah, in pregnancy.
Flu vaccine is very common. We should give
Yes.
every woman.
Yes.
Because this is our routine. We are giving the every woman flu vaccine during the pregnancy. And now
Yes.
everyone is doing this.
Dr. Vishang, I can see a beautiful photograph behind you.
Vishang is also.
That's my consulting room, sir.
Yeah,
I am
can
in
you-
IVF field, so the patient comes in my IVF, the consulting room. The first thing they see beside a doctor is the face of the fetus.
Can you just send us on group so that we can copy paste it?
Sure, sir. I'll send the data.
Thank you, Dr.
Best wishes, sir,
Ma'am.
for your upcoming election. You
Thank
are
you, sir.
already doing great as a president IAG, and
That will not
we
be
will
the
try our best.
VP this time.
Yes, sir.
I'm
Thank
sure.
Yes, sir.
So vote of thanks officially from Dr. Monica Gupta.
I thank you, our chief guest Parag Beniwale sir, our guest of honor Veena Acharya madam, and Kiran Kurtuki sir, and our moderator Kalyan sir, who is the program director, our expert Jagruti madam, and all the esteemed panelists who have joined and spared the time, and all the my co-coordinator Deepika, and the persons who are joined with us and watching this program, and the Corona team. And I request to be with there on every Thursday. We are having a program on every Thursday. Please do join. Thank you, everyone.
Thank you so much. Best wishes, sir.
Thank you,
We are
everyone.
with you.
Good night, please. Thank you.
Thank you so
Thank you.
much. Best wishes,
Good night.
sir.
Best wishes.
Okay. Thank you.
Thank you, sir. Thank you. It was a very
Good
interesting
night,
panel, sir.
everyone.
You covered everything and such good cases, and the panelists were excellent.
Dr. Deepika, this is all because of the support from the support team, like you, Dr. Monica Gupta, Dr. Monica Umbardhan,
Yes.
and all well-wishers who are doing such a
So
wonderful.
we are always with you.
So we are always there with you, and all our best wishes. Dil se matlab best wishes for you, sir.
Thank you.
So we
Thank you. Thank you, everybody.
Bye. Thank you.
Thank
from
you.
the PAC
Thank you.
committee
Thank you, sir.
chairperson, from
Thank
vice
you,
president
everyone.
and then president. Foxy.
Starboard. Thank you, Monica ma'am. to
Thank
making
you.
me
Bye.
Thank
Good
you.
night.
Bye. Good night.
Bye.
Good night.